शुरू करें मैं? Good morning, respected sir, my senior colleagues. I'll be presenting on developments and recent advances in pancreatic surgery, and mostly based on the article by Omar Javed and Manmohan Singh Sal, where they published from the Italian journal. So, starting with the introduction, the pancreatic cancer is one of the most lethal malignancies, and with mortality less than 2% in high volume centers, and mostly indicated for pancreatic ductal adenocarcinoma or perioperative carcinomas, or even for benign indications like cyst trauma and pancreatitis. And only 15 to 20% of the cases are resectable at the time of presentation in pancreatic state. It has a extremely high mortality and morbidity and very limited patient survival, due to which it was very debatable surgery in mid 20th century. That's why it took a very long time to leap forward in a recent ages. So, according to the CA database, 5-year overall survival is only 8.5% among all stages, and the incidence of pancreatic cancer is rising both in Western and developing nations, which makes it a major global health concern as of now. So, the journal talks about the centralization effect in the pancreatic surgery, which basically means there is an inverse correlation between the hospital volume and post-operative mortality, meaning that the mortality was seen high in the low volume centers, such as in a study by Burkmeyer et al. In 2002. In the cases in the hospital with less than one resection per year or lower volume, the mortality was seen up to 16.3%. And in hospital where resections are more than 16 resections per year, the mortality rate had decreased to 3.8% with decrease in morbidity as well. So the centralization is influenced by hospital volume and surgeons' individual experience as well, but the data has definitely shown that the higher volume center has lesser mortality. So this is also another study from the US with a large number of the cases, which have shown that the high volume centers have 2 or less mortality per year. So another advancement in recent time is the application of the ERAS protocol in pancreatic surgery. The literature from this is from the Lesson et al. Annual Surgery 2022 meta-analysis of 15 RCTs, where utilization of the ERAS protocol has led to the mean hospital stay of 7 days compared to 10 days, with significant statistical difference. And major complications rate also decreased in 18% from 32%. Delayed gastric rate from 12 to 24%, significantly half. And opioid has also been decreased with application of the ERAS protocol. It basically means the proper preoperative planning as per the ERAS protocol and post-operative early mobilization, early feeding. But many factors such as the hospital protocols and surgeons' ethics, surgeons' principle has limited the use of ERAS in pancreatic surgery. And moving on to the advances in the surgical technique in pancreatic surgery, it is still one of the most radical surgery, often can be done for borderline as well as locally advanced tumors as well, which becomes more radical. And over the time, the techniques have been refined to improve the resectability, enhance the local tumor control, and extend to vascular and multivisceral resection, keeping the patients making the patients R0 resection in selected cases, which will definitely benefit the patient. And despite the increased morbidity, complete tumor removal still remains only options for the long-term survival in these advanced cases. So, on the surgical advancement, the first advancement was the artery first and uncinate first approaches, which was developed to improve the vascular control before the resection, and which has 4 main benefits. That is, it has an early assessment of resectability before the irreversible steps has commenced, and it improves the medial and retroperitoneal margin clearance. It has a better identification of the common hepatic artery, even in the anomalous position. and it reduces the venous congestion, intraoperative blood loss. And they also allow an early assessment of resection without unnecessarily prolonging the surgery before irreversible steps. But before discussing more on the surgical approaches, I'd like to talk on the few historical papers. The first one was from Takasaki et al. After the 30 years of developing the Whipple's procedure, the Takao Takasaki from the Japan, he first described the uncinate first approach. And then later in 1990s, the technical refinement was done by, in 1995, John Hoffman, who advocated the early arterial control in Whipple's procedure, and then Masao Kobayashi from Japan, who introduced the posterior SMA approach for bulky pancreatic tumors. And Wade et al. They classified the 6 approaches for the artery first technique and published it in Annals of Surgery 2010. And Hackert et al. From the Heidelberg, Professor Thilo Hackert from Heidelberg proved that increased R0 rate in borderline borderline resectable cases by artery first approach, and they also developed the techniques for pancreatic duodenostomy, which also PJ anastomosis, which has also proved to be lessen the POPF. And also the Dr. Claudio Bassi from Italy, who has adopted the artery first for artery first for the locally advanced cases with improved RZ resection. So this was from the papers of Witz et al. The 6 classified approach of artery first approach, where the posterior SMA first approach, left posterior SMA first approach, CHA first, and right dorsal or Adachi was invented in Japan. And inferior or uncinate first approach, which was first given by Takasaki et al. And then anterior artery first or SMA anterior surface first approach. These 6 different approaches with the anatomical focus was clearly given in the Witz et al. Article. The posterior SMA first approach were indicated for tumors with suspected SMA contact, where left posterior SMA first approach is locally advanced body tumors, and CHA first approach is locally advanced CHA GTA involvement tumors, and right dorsal, where the SMA right neural plexus were focused initially, where the plexus infiltration were seen. And uncinate first approach was done in large uncinate large uncinate tumors, which was published by Takasaki et al. And then SMA anterior surface first approach was for early resectability assessment, which is the most accepted and accepted form, which was pioneered by Hoffman et al. And then the surgical resection advanced to the venous involvement, the resection of the cases with venous involvement with the venous resection as well as repair. In 1951, first assembly resection by Moore et al. Was done, and it was initially contraindication where the venous involvement was seen, but they did it in selected cases. And because up to 35% of cases presented with vascular invasion, and R0 resection was only key to the survival, so they did the venous resection, and it was shown to be very helpful in case of the overall survival at that time. So if we see the meta-analysis of the 41 studies, the venous resection has longer surgery time and higher blood loss, and slightly higher 30-day mortality rate with venous resection versus without resection. But R0 rate is also lower, that is 60.5% versus 68.7%, and 3-year survival and 5-year survival, if done correctly, is higher in case of the venous resection case, that is 24.5% versus 29%, and 5-year survival 12% versus 15% with significant statistical difference. So there, I have shown the 4 different types of the venous repair that can be done. We have discussed this already. Another multi-center review of the UK also revealed that the venous resection, even though it has the in hospital mortality is similar. The median survival extends by minimal margin after the resection cases. To conclude, it is safe, feasible, and widely accepted when R0 resection is achievable, which will definitely benefit the patient. And then the surgical technique advanced further with the widening the field of resection with the introduction of neoadjuvant therapy, which became the new standard as the trials came on. The goal was to downstage the tumor, treat the micrometastasis, and improve the RZ resection. And it is now the first line for borderline resectable or locally advanced tumors, and also supported by the large study like PREOPANC trial, which has shown increased R0 resection rate up to 60% in some series. So current consensus is the neoadjuvant therapy is mandatory for the arterial involvement, borderline resectable with arterial involvement, and it is debatable for the venous involvement as per the literature. So the PREOPANC trial was at the regimen gemcitabine plus RT, which showed the resection rate of 61%. With increased R0 resection rate and median overall survival of 17.1 months. Another trial, that is Alliance trial, was for FOLFIRINOX, which showed the resection rate of 68% with significantly improved overall survival of 23.7 months. So the FOLFIRINOX was seen to be better in case of the locally advanced pancreatic cancer. And it has seen up to 30% conversion to resectable with the definite benefit to the patient. And another is the adjuvant therapy in case of the pancreatic tumor. The adjuvant therapy was started very early. It had always good outcome to eliminate the residual disease post-resection. And current standard is to include the M-FOLFIRINOX from CORI's 24 study, which has a median survival 54.4 months overall survival versus 35 months of median survival for 35 months overall survival for gemcitabine. And gemcitabine capecitabine combination as per the SPAC4 trial was 28 months of overall survival versus 25.5 months of gemcitabine alone. So the combination, rather than the combination, M-FOLFIRINOX had the significant overall survival compared to the gemcitabine-based therapy. But the most common challenge is only 60% of the patient complete adjuvant therapy, that too on time, and due to the complications. And the ongoing trials are testing the complete total therapy, that is neoadjuvant, then surgery, then adjuvant, with the newer trials testing the median survival with the total therapies. And earlier in some books, the etoposide was shown to have some roles in the PDSC, but etoposide has shown to be of no role in PDSC. It may be given in neuroendocrine tumors, SNR cell carcinoma, but it is not recommended in pancreatic ductal adenocarcinoma. And also the role of olaparib at the pancreatic ductal adenocarcinoma is a BRCA mutant carrying carcinoma. The role of olaparib is also under investigation by many trials, and it has shown to be beneficial. Then comes the era of the arterial resection. The historical data was discouraging, with the morbidity ranging from 16.7% to 100% and mortality up to 45%. And 5x survival was 0% in older series up to 1990. And the in modern era, in a specialized center, they report the improved outcome with better patient selection after the chemotherapy and advanced reconstruction technique. But still, is not recommended. It's not in use commonly. It only considered only in trials and in exceptional cases. And these data came to the development of the arterial divestment techniques. The periarterial divestment techniques was a concept where the subadventitial dissection of the artery was done to remove the tumor. It's like the peeling the orange, taking out the orange peel from the artery along with the tumor. So the key concept was it was an alternative to arterial dissection. the radical tumor clearance without sacrificing the arteries. And later on, it was adopted for laparoscopy, and it became an ideal which avoids the complex lap arterial reconstruction. The techniques was subadventitial dissection, where the artery was identified, adventitia was opened, and tumor was divested, that is peeled off from the artery under the magnification, and the flow was preserved to maintain the integrity, where anastomosis was not required. So the divestment procedure and dissection procedure, it was laparoscopy friendly, but resection procedure definitely required the open conversion, and cumbersome, also poor outcome in the patient. And then for locally advanced and borderline, widening the scope of the resection, the triangle operation was developed from the Heidelberg Institute. In case of the suspected encasement, the immediate frozen section analysis was done, and there was two possible outcomes. It was only done after the neoadjuvant therapy. There were two possible outcomes. If there is a viable tumor, we have to proceed only if the technically resectable or reconstructable cases, or the patient is fit and permits high risk surgery. But if frozen section shows the fibrotic tissue only, the triangle operation can be done. It is radical, but it is artery preserving. And that's why the frozen section matters during the triangle operation, because it avoids the futile dissection and also salvages the RZ resection. So this was the operative video and a illustrated video taken from the Heidelberg et al. Literature of the Heidelberg et al. Shown the triangle from the anterior, posterior, lateral view, the triangle forming from the portal vein, SMA, and then CSA. All the dissection is done, the subadventitial dissection is done along with the nodes and surrounding tissues. So how the triangle operation is different from the periarterial divestment is that it involves the en bloc dissection of the perivascular soft tissues, mesopancreas also, whereas periarterial divestment has the peeling off of the arterial subadventitia only along with the tumor. And there is a radical dissection around the arteries, and in triangle operation with the overall dissection, where in periarterial divestment, adventitia is removed after the removal of the tumor. So triangle operation is only indicated in the fibrotic adhesion. Periarterial divestment is indicating the suspected tumor encasement, where viable tumor is possible but dissectable of the adventitia. And these are best for the borderline, both are best for the borderline or locally advanced tumor. The laparoscopic feasibility is seen more in the periarterial divestment. The triangle operation is challenging. We have to do 360 degree dissection around the artery with the mesopancreas dissection, whereas periarterial divestment is done only in the one plane where the tumor is attached. And another advances was in development was in the minimally invasive pancreaticoduodenectomy, which was the milestone in adoption, first done in early 1990s, but due to longer learning curve and reconstruction needed, it was slowly adopted, and also the cost concerns was there, and slowly the robotic revolution started in the late 1990s with the development of the Da Vinci platform and 3D visualization. And robotic pancreaticoduodenectomy was done by Guglianotti et al. In Italy in early 2000. So the recent trials, these are the key completed trials, RCTs, which involves a minimally invasive versus the open pancreaticoduodenectomy. First one is from China, Wang et al., 14 centers RCT, who found that there is decreased length of stay and no difference in measure mobility versus the two. And in plot study, Pandulab study from Spanish, there is decreased length of stay and overall decreased overall complication as compared to the open surgery in laparoscopic pancreatictomy. And as per the Leopard 2, it is a multi-center double-blinded trial. It was terminated early because of the high 90-day mortality, but it has shown the comparable recovery and safe alternative if done in the high volume center. And another is the robotic pancreatic duodenectomy, the comparison of which versus laparoscopy and open is being done by many trials. And there is lesser conversion rate in robotic and increased splenic vessel preservation. It is as compared to the open, there is lesser length of stay and lesser readmissions as per the John Hopkins data. And also the robotic pancreaticoduodenectomy is very easy to learn as per the Hopkins data. And the meta-analysis consensus as per 2020-23 study also shows that the robotic has better length of stay, decreased blood loss, but there is an increased operative time and equivalent measure complication of POPF and delayed gastric emptying, and the oncological equivalence is also same. And I've tried to include very few things on the distal pancreatectomy or the advancement of ramps, where the earlier, initially distal pancreatectomy used to be done by left to right approach, but ramps, introduction of the ramps started the era of the right to left distal pancreatectomy, which entails the more lymph node retrieval and better local disease control and improved margin clearance, developed by Takahashi et al. In initial study. It showed the better recurrence-free and overall survival, which also gives the scope of the distal pancreatectomy. And in distal pancreatectomy, the key randomized trial, that is Leopard trial and also LAPOP trial, they both emphasize on the decreased blood loss and decreased delayed gastric emptying. As in RAMS, there was no difference in POPF or 90-day mortality and other complications as in RAMS versus classical or conventional distal pancreatectomy. And this was the LAPOP trial where laparoscopic RAMS versus open RAMS was compared, which showed the decreased length of stay in laparoscopic. It was only 1 day, and in secondly, decreased time to recover in laparoscopic RAMS versus the open RAMS. And another is IMI-PRT group. We combined the LAPOP and Leopard plus other RCTs, and they have said that the trend of increased POPF with minimally invasive distal pancreatectomy, it is still debatable, and similar major complication rate. And so the adoption of laparoscopy in distal pancreatectomy is still debatable because of the conflicting data in POPF and oncologic efficacy. And these are now is the era of the very minimal invasive techniques like nanoknife. These are usually done in the unresectable pancreatic cancer. We use the high voltage electrical pulses to destroy the tumor cells. A knife or rod-like knife are placed around the tumor cells. They have the better advantage versus microwave or radio wave ablation, because they do not have the heat loss or surrounding heat effect. They preserve the blood vessel and critical structures and ideal for the tumor near the vessels. They create the nanopore by electrical pulse and leads the tumor to apoptosis, lesser collateral damage, and combined with the chemotherapy and followed by the surgery, better artery resection can be also achieved after the nanoknife. So NCCM guidelines is still under the investigation as per the version 24.3, and there are ongoing trials for cold fire 2, where IRE, that is nanoknife plus chemo versus chemo alone, and borderline resectable tumors, downsizing by nanoknife is being under investigated, which will definitely become a routine in a time to come. So study like Impala or Panfire, they have shown that the major complication rate are very lesser in case of the IRE plus chemo only without the surgery, with the progression-free survival of 10 months. as per the Impala, and progression-free survival of the 9 months as per the PANFA trial. This was done in stage 3 and 4, locally advanced pancreatic cancer. So moving to the more future, the precision medicine is definitely the future in any cancer, and it is still the case in the pancreatic surgery. The current drugs target some mutated gene like KRAS or BRCA1/2, NTRK, and MSI. The frequency the KRAS frequency is seen very high in PTAC. The targeted therapy like sotorasib and are under the phase 3 investigation. These are newer drugs. And BRCA1/2 PARP inhibitors like olaparib are now FDA approved as per the POLO trial, is being used even after the surgery for high risk group for 1 year. And MRTK inhibitor like larotrectinib, which is under the phase 2 trial as per the Navigate trial, but the result of which is very conflicting in the initial phase as well. And the MSIS, the drug Keytruda or pembrolizumab, is FDA approved and has shown to be very beneficial if combined with the KRAS G12C. So the KRAS G12C inhibitors has shown to have 30 to 50% disease control in case of unresectable cases, and on combined with olaparib, it has increased the progression-free survival as per the POLO trial. And in future, we can see the KRAS, the one that is recommended by NCCN is KRAS G12C. That is only epigene of the KRAS. But there are other epigenes, that is G12D, G12V, and G12R. So we have KRAS PAN inhibitors under the development, and the RMC 6236, the drug, which is already in phase 2 trial. So this might be one future direction for the chemotherapy of the pancreatic cancer. And another, the stromal targeting agent, the TGF beta inhibitors plus immunotherapy. And also the AI-driven platforms are under use from in various literature from John Hopkins, that is Tempus XT and IBM Watson, for trial matching of the cases to keep them in the KRAS PAN inhibitors. So they will do the epigenetic sequencing and keep the trial as per the AI matching. And definitely the future direction is the KRAS PAN inhibitors plus checkpoint inhibitors to give patient progression-free survival in the coming days.
How this analysis is guided?
This is image guided, sir.
The ultrasound CT guided.
CT guided, just like RFA method. So it is placed directly above the tumors from image guided by the CT scan with the visualization of the CT scan. There are two knives in two sides, and it is placed directly from that. Right.
Any questions, any comments? First of all, from presidents, because we have the two consecutive lectures on this same topic regarding advanced surgery for the pancreatic cancer. Anything in particular to the Whipple's procedure? I think Assis has worked a lot with the pancreatic surgery in our unit. Koirala basically. So far, 35. So he has the largest number of experience out of all of you. So there is certain nuances that I want to highlight. I think personally in Nepal, this center for very complex surgery, I still recognize that should be the KMC. Praveen Thapa and his team, they are doing the wonderful job, very complex surgery that he has mentioned, the arterial dissection. I have read his articles from this book regarding the SMA dissection and also some reconstruction for the hepatic artery, celiac artery, etc. So I think they have got the largest number of the complex surgery in regards to the Whipple's procedure. So as the volume-wise also they are good. In our hospital, in our unit, I think we have 200 plus Whipple surgery in the last 6 years. It is also reasonable. because other units are also performing the Whipple surgery. In our unit particularly, we people have performed about 200 surgery. So I have fixed mindset regarding the Whipple's procedure. So he has very much said that in a way of improvement, first we have got in every text with a classical way of doing the Whipples. Means portal vein approach. You identify the portal vein, make the tunnel, divide the pancreatic neck, and then proceed forwards. Which I think should not be used right now at the present scenario. Whoever has invented this portal vein approach, portal vein first approach, or vein first approach, they have also changed their mindset. They make the tunnel, but they don't divide the pancreatic neck in the beginning. Because that will cause unnecessary bleeding from the parenchyma of the pancreas, because you have not controlled any vessels to the pancreas. So even though you have developed the channel, then you move to other parts of the procedure, like finding out GD or dividing some of the blood vessels to the uncinate process, etc., mobilizing the stomach or second, third part, or fourth part of the duodenum, etc. So my mindset since last 6 years is that the best approach for any kind of Whipple surgery should be the superior pediatric artery first approach. He has mentioned 6 approaches. For myself, I have selected only 3 approaches out of all the 6, which I have been able to utilize each and every time. I think each and every time you will be successful if it is obviously unresectable. So I think you have observed the cases. So I found that whatever was described, the posterior most approach. You see, this is the SNP, and this is the SNP. So for most of the tumor, this is the duodenum, right? For the most of the cases, if it is located in the perioperative region, again, I prefer to do the SNP first approach. Why? For a few reasons that you will identify the anomalies. Like yesterday, we have a restaurant, he has got a very peculiar anatomical abnormality that the common hepatic artery was coming from the descendants, along with the left hepatic artery which was coming from the septum. So the 2 anomalies were identified in our case. And also first sentinel vein was not a classical vein. I forgot to identify the first sentinel as such during the surgery, but it was not seen like classical behind the semi looking around. So it was absent in our case yesterday. So this kind of anomalies can be found very well in the SLF. So this one thing. Second thing, yesterday we ligated, I think 3 inferior pancreaticoduodenectomy artery. So if you are doing the portal vein first approach, you may not be able to identify this very well, but in the context of the SLF first approach, it's very well seen. You can ligate those vessels very well. Therefore, it actually minimizes the bleeding intraoperatively, and also will cause less post-operative embolism. So that is also very much essential for that. Third thing that I found that during SMF first approach, if you are planning for the vascular resection, that can be done like you have the control of the portal vein assembly, you have control of the assembly, so you can plan the vascular resection. So if you are planning for the vascular resection, assembly approach is the way to go. So far, what is the perioperative tumor is concerned, there is no encasement because far away from these vessels. There may be the question why to do the SM approach. If you can go along with the simple classic approach, again I emphasize for the reasons that you identify those structures very well, it's always recommended to go for the SM. That will not cause any harm. Now, how to go for the SM approach? So 6 approaches have been identified. The first approach that he mentioned, when I began my career in the Whipple surgery, the SMA approach. So what I used to do, this is the SMA artery, this is the ciliatum. So here is somewhere the pancreas, right? So the posterior approach is identifying the superior mesenteric artery from the origin of the aorta. Yesterday we saw very clearly the SMA from the original aorta, but I did not touch it because nothing you can get much benefit from that unless the superior mesenteric artery is invaded when it processes in the parenchyma, just crossing through the parenchyma, somewhere around the parenchyma. So in those cases, you have to take the controlled proximity, and also when you get this to the distal, in that part for control, you can take it to the swing at the origin and the distal part. Right? That can be done. Otherwise, I didn't find much importance of clearing SML from the root. One more thing that you want to clear very well the 14 lymph node. 14 is that runs around the perioperative artery. So that's divided into 14A, 14B, and then the proximal along this is the secondary lymph artery. This is the proximal divided into two parts. This is the 14A lymph node. It's the proximal one. 14B is the distal 1/3 of the SML. These nodes have to be clear. That has been defined in the NCCNs. If you go with the portal vein approach, I don't know how you're going to take out those lymph nodes. That's why it becomes reasonable that even if we do go for the classical approach, we have to take out, identify the SMA and take out the lymph nodes around the SMA. So this, to take out even 14A and 14B, whatever is the location of the tumor, let it be the periampular, let it be the gastrus ampulla, distal severe, heard pancreas on scenario, you have to take out those lymph nodes according to the guidelines. So therefore, for those many SMA approaches, it's very good. So now how we are going to proceed? So you might have seen yesterday. So this is the assembly. This is the assembly. The most of the time for the periampular, the surgeon pulls the pancreas towards himself. And the assistant, what they do is he does with his finger, takes the SMB, rolls like this. SMB lies medially, SMB lies like that, right? So he pulls with the finger like this, so that the SMA margin becomes visible. So in that way, you are protecting the SMB, that is protected by the finger of the assistant, and the surgeon visualizes very well the margin of the SMB. Now, once you have visualized the margin, of course, then it depends on the philosophy. What kind of the radicality you want to do? So therefore, he has going to wanted to tell that thing, but he missed it. So there is the three types of lymphatic dissection. This type only LV1, LV2, and LV3. That was very well elaborated by Dr. The basic began. Dr. began. He has very much highlighted about this LV1 type 1, LV2 type, and LV3. So what is this philosophy LV type? This was done by the Dr. Inoue. Maybe you must be knowing this from Japan. He is the person surgeon who invented poem for the cardiac. So he was a surgeon. He's the surgeon, but he was inventor of the poem. So he has defined the cell level and LV2. So most of the time in the perioperative carcinoma, LV type 1 may be sufficient or borderline tumors like mucinous IPMN or some serous systemic carcinoma, etc. It's totally localized or matter sample LV1 may be enough. But for the head of the pancreas, the totally advanced to be LV2 or LV3 has to be done. So it means you have to go along the assembly, find out the nerve plexus, and then you take out those nerve plexus. So remember also, if this is the assembly, so you take out the plexus only to the right circumference of the assembly, not throughout, of course. So from 5 o'clock to the 11 o'clock. So this is the assembly circumference. So from this part is the 5 o'clock, which is the 11 o'clock. So this circumference has to be cleared in order to take out the LV2 or LV3 dissection. That's also very important. The next variable, this topic he has mentioned very well regarding the ERAS protocol. So now if you ask, I'm talking about how we practice the recent advances. Are we practicing the same thing in our unit or not? So regarding the ERAS protocol, we are a little bit reluctant, but we are sticking to the protocol of IGS and PS. It means we allow oral injection on the 4th post-operative day. If you skip beyond 3rd post-operative day, it means that should be classified as delayed gastric emptying. In order not to classify as delayed gastric emptying, we on the 4th post-operative remove the NG tube, allow the person orally, so that we have to minimize the delayed gastric emptying. So there are the people, surgeons who allow even on the first post-operative day, even on the same post-operative, I'm a little bit reluctant because we know category of people are different. The next thing that we have found is if the patient presents with a jaundice, this is the classical scenario that most of the patients come to us. So how will you approach? Let's suppose we have the patient who has got a jaundice of proton bilirubin 10. So would you consider for the surgery first, or we would consider for the drainage procedure first? So for the less than 15, it is not essential. Because we have seen yesterday, the ERCP was done Now, how much of that, how many of the reasons, how much of the reasons were present during the surgery? It makes your job more complicated. The morbidity goes high because the surgical site infection and also intraoperative bleeding, etc., dividing the region. So if the level of the bilirubin is less than 15, there's no point going for the clearance unless there are other parameters, like if the patient has cholangitis despite the lower level of the jaundice, if the tumor is unresectable when the surgery is not being done, locally advanced tumors, T3 or T4 lesion, multiple bulky nodes, then if you are planning for the neoadjuvant chemotherapy, then indeed you have to do the ERC first biliary stenting and then go for, meaning downstage the tumor with the chemotherapy neoadjuvant and take the patient for the surgery. Now let's suppose that patient has a jaundice 10, locally advanced, you did the ERCP, downstage that, bilirubin comes down in 2 weeks or 3 weeks of time, then you have started with the chemotherapy. Then after chemotherapy, how many cycles of chemotherapy, what kind of chemotherapy will you propose to the patient? You have shown in your guideline a certain category of chemotherapy which helps most. So what would you prefer for the patient?
M-folfirinox as shown to
folfirinox regime or the classical that was nab-paclitaxel and levetiracetam. You don't need to, we are surgeons, please do not remember a list of chemotherapy agents. The only two things, the classical was nab-paclitaxel plus levetiracetam. Right now the folfirinox, M-folfirinox is the latest version which we have to propose. It's very toxic, so we have to select the patient. If the folfirinox cannot be tolerated by the patient, then you go for the nab-paclitaxel. It is easily tolerated than the folfirinox. So you have to decide on that. Let's take the second scenario. Patient has the perioperative CA. It's resectable. He has got the bilirubin level of 20. Then how will you proceed? Like in our patient that we did yesterday, the tumor was resectable at the time of presentation. His level, I don't remember what was the level of the bilirubin, but I think it was quite high. 15 or so, etc. So what you now, how will you proceed with that patient?
more than 15. Since bilirubin is more than 15, I'll first
drain the
ERC.
So how long you will wait? 1 month, 2 months, 3 months?
4 weeks.
1 week?
No,
5 days? How long?
2 weeks.
What's the rationale? Generally, you are correct that you wait for 2 to 3 weeks, not more than that, because if you wait longer, the disease will progress. If you do earlier, the purpose will be not fulfilled, and there were more reasons also. The classical window is 2 to 3 weeks, then you proceed for the surgery. That's good. So that was done in our case. I think it was done 10 days ago. I do not remember.
13 days ago.
Whatever. So we proceeded for the surgery. That's one. The next thing that I want to highlight is you mentioned about the role of immunotherapy and the targeted therapy. So he very well, just to catch it, but these questions may come into the examination. What's the probability of BRCA1 and BRCA2 positivity, like in the breast cancer, triple is quite high. In the pancreatic cancer, he said about 2%.
Yeah.
So there is not much role of this very rare patient that will have the BRCA1 and BRCA2 positivity. If it's positive, definitely we have to cover with the pancreatic. The next thing he talked about also the MSI high and deficient MMR. So that's also about 2% of the cases. So summarizing, the role of immunotherapy and this targeted therapy are quite less at present scenario. Maybe the future will be different. They are having several trials in the future will show a benefit of that, but as of now, only a limited patients are benefited from this kind of thing. The another next thing, he said a lot about the reconstruction. So he said about the venous reconstruction. He talked about the arterial reconstruction. So I would like to ask you, let's suppose the patient is having type 4 reconstruction. It means the portal vein was incised and it was transposed in between some grafts. So what kind of graft do we choose for your patient? In our scenario, we are not living in a very high country. In our scenario, feasibility.
In our scenario, we can put tumularized peritoneal.
The one thing very good is the peritoneum. Local peritoneum. It is very good. You don't need just only take the mesothelial surface inside. It will work like the endothelium. One, then next one, Pericardium, you have to open the chest cavity, so that's very visible.
You can use the splenic artery.
No, vein coli don't use
The
that.
vein-
The vein never use that. Yeah, the next thing is very massive is the left renal vein, and in the total confluence in the left renal is very easy. Next thing, long segment. Yeah, great saphenous vein. This is a very good option. The great saphenous vein, you can make the spiral vein in the venous stomach. That's one thing. Now, what is the? Let's suppose the scenario: the patient has got the tumor involvement along segment in the portal hypertension, or portal hypertension, or the patient has got the thrombosis. Only the patient might be the SMB portal and thrombosis. Well, even I will say that but totally it's thrombosed. So, here the resection we should have been otherwise. Now I recognize it. Tip context, what will we do? Because we have to the middle portal hypertension features also. And if you are planning for the resection of the confluence, then how we proceed? This is the SMB, this is the splenic vein. Now you are trying to excite this part, irrespective whether there is the program strong. So now you will understand end to end robotic. What's the maximum extent that you can excite and make the For that we have to do the generous preparation, right? Semicolon has to be pulled up and liver has to be mobilized down. So you can make the interior. So now the scenario then the splenic vein. There's the confidence here or here tumor. So do you implant the splenic vein inside the re-anastomosis, right? Or you do not implant the splenic? Is there some role? Scenario question. Double exercise girl. There is the splenic vein. What you'll do with the splenic? If splenic vein anastomosis, if that is going to hold, there's some block hold your anastomosis. If you divide it, it will come easily, right? Because the splenic vein is holding. So if you divide it, do you reimplant or not? What will be the deciding factor? Any ideas? Well, the deciding factor will be it is reasonable to reimplant it, but that will cause take extra maybe 30 minutes of time, right? Or 20 minutes of time. So for that, you remember, so most of the 2/3 of scenario is the IM is training into the spleen, right? 2/3 of that. So if it is training, then you can divide it because there will be the bypass, then there will be no sinistral program. But that can be. But if the IM is training based on your portal vein, you have to reimplant this splenic vein either into the portal vein or you have to do the spleno shunt. Some portal system or spleno systemic shunt. So that has to be done because you are causing the sinistral hypertension in the future. They were saying you are the part. So, our scenario will give a name. Peritoneum is the first choice, second choice the great saphenous vein, third choice will be left ventricle. हामीले जनरली लेफ्ट र काटो दिमागमा हामीलाई डर हुन्छ यो कार्डियोको गुनाहरू कस्तो छ के छ धेरै डिपमा गयो त्यो उसको किडनी ड्यामेज होला कि लेफ्ट साइडको है त्यही भएर प्रायोरिटी पाउँछ पेरिटोनियम ग्रेट saphenous vein थर्डमा चाहिँ लेफ्ट ventricle. And now the situation for the artery ma long it was used to gain the same the veins. Veins were you never use the peritoneum for the artery reconstruction. End-to-end anastomosis may be possible, may not be. Most of the time it's not possible. You have to interpose some of the things, conduit in between. So the first option should be always the splenic artery. It's possible splenic artery reverse cardium, lateral cardium. It is possible just the common hepatic artery, some reverse cardium. If it possible, what do you think? What will you use? Let's suppose segment of the SMA has been excised. If we have done the splenectomy also, there is a probability that splenic artery on pins, autologous splenic artery can be harvested and can be fixed in between. Do you think it's a good idea? If you have done the Whipple or some distal pancreatic the upper back procedure along with the splenectomy, then the splenic artery on the pins, excised intercourse.
Brains
सकिन्छ, but it's not a good idea. Splenic artery is tortuous. It has multiple divisions. You have to like at each and every. There are the high chances of pseudo-aneurysm formation in the posterior period. So sphenic artery is to reverse the is good option, but autologous graft is not very good depending upon the tortuosity of the sphenic artery. So what comes next then? When shutdown is very yes, but durability is questionable. When artery goes with standard preferred there will be the dilatation of the veins and then the durability is the issue. So the best answer will be the artery again. What customized was to know is like imprint top also to say use one. So cadaveric अथवा autologous to हामीसँग option छैन. हामीले यहाँ युज गर्ने भनेको the great seconds then कि त sphenic artery कि त यो SFA superficial femoral artery. त्यस्तो कन्डिसन आयो भने म्याच गर्छ डायमिटर superior femoral artery लिने हार्भेस्ट गर्ने tortuous पनि हुँदैन स्ट्रेट हुन्छ. It's a good idea. Your arterial reconstruction lab is SFA use गर्यो टेस्ट वा यो इभन ग्रेट
So यो रेडियल सकिन्छ सर अल्लाको
रेडियल पनि सकिन्छ डायमिटर अलिक म्याच गर्न सक्छ किनभने एसएफए चाहिँ एकदम म्याच गर्छ रेडियल पनि सकिन्छ किनभने कम गालीबाट हुन्छ अनि यो पनि कुरा या त डायमिटर कम रेडियल आर्टरी जस्तो हेपाटिक आर्टरी प्रक्रिया कुनै रिप्लेस हेपाटिक आर्टरी त्यसलाई गर्नु छ भने यस्तो सानो डायमिटर म्याच गर्छ. अरू केही कमेन्ट्सहरू फ्युचर इज डेफिनेटली किनभने अहिले अपकमिङ के छ भने venous resection is no more the contraindication for surgery. Arterial resection is controversial now. The upcoming reports are there that arterial resection may be considered and also it has got better outcome. The future will show. Keshav, the comments say